Okay, so hello everyone. My name is Don. Some of you guys had me last quarter for PFM Crown, number 9 PFM Crown. Today's lecture is going to be about um, introduction to prosthodontics. Prosthodontics is a subspecialty. Actually, no, it is a specialty, one of the 12 specialties in dentistry, and it's a very, very interesting specialty. So I'll be talking about the scope and also some of the common procedures and some basic concepts behind those each procedures. Okay, let me just share this. Let me just start the slideshow here. All right. So before I begin, I just want to give credit to my content mentor, Dr. Tingling Chang. She's the chair of Prosthodontics at UCLA, and she's gone over this presentation multiple times and given me a lot of tips and advice on making this content accurate and also digestible. So I give her a lot of credit for this presentation. Okay, so let's begin. Introduction to Prosthodontics. So I have an outline here, and I've basically broken it down to the main branches of prosthodontics. So first, we're going to start with what is pros, and then the four main branches of prosthodontics. All right, so have you guys heard of prosthodontics? You guys can kind of like shout out, or probably not. A lot of people don't know what it is. It's not as common as like ortho or oral surgery. This specialty is not as commonly talked about. So let's see. According to National Prosthodontist Awareness Week, so there's an awareness week every year because the specialty is not as well known as it should be. So according to NPA, this is directly from the American College of Prosthodontics. A prosthodontist specializes in the aesthetic restoration of broken down teeth and the replacement of missing teeth. Prosthodontists have an advanced understanding of your smile's optimal look and function. And I think this is really where prosthodontists shine compared to, I guess, other specialists or general dentists. We have a very deep understanding of the function of the bite, the jaw, and speech and aesthetics, so that whenever we see like a very complicated patient case with maybe like really weird bite, really challenging aesthetics, prosthodontists can handle it very well. Complex cases are what we specialize in. In simple terms, prosthodontists are the specialists for dentures, implants, crowns, bridges, and veneers. So pros means prosthetic, right? So these all have to do with replacing teeth. And dentist obviously means dentist. And finally, prosthodontist, in order to become a prosthodontist, you have to receive 3 years of additional training, 3 years of residency after dental school. All right, now let's go into the field itself. Now let's start with some basics here. Indirect restoration, since you guys have already had some lectures on indirect restorations. So again, indirect restoration means it's made indirectly, not directly in the mouth. So it's usually made outside, outside the mouth, usually in the lab. What are some common types of indirect restorations? Full coverage crowns is the most common type. Everyone knows this. It's basically a crown or a cap that covers all 5 surfaces of a tooth. Okay, the whole tooth crown gets covered with a restorative material. I think there's chat. Sorry. Oh, okay, everyone said yes. Oh, okay, so a lot of people know what process. Great. And other types include, I think this is getting more common nowadays. More and more dentists are trying to be more conservative. Conservative dentistry is becoming more popular. So full coverage crowns are done less frequently, although it's still the most frequent restoration that's placed today. It's done less frequently than in the past. Instead, dentists try to place partial coverage restorations, which don't cover the whole surface, all 5 surfaces, but only part of the tooth. So there's a few different types. On an onlay is a partial coverage restoration that involves covering a cusp of a tooth. Okay, so a cusp. You guys had like dental anatomy on one of the lectures, right? So a cusp again is basically one of these spiky hill-like points on the tooth. And these are usually the workhorse of the tooth. So if the decay is so big that you need to include the cusp, then you would transition from a filling to an onlay, partial coverage restoration. Another partial coverage, a very common one, is veneers. It's usually for aesthetic, cosmetic purposes, and usually it covers the incisal or the occlusal and the facial aspect. So these are mostly for surfaces that only show, so the facial for the most part. There's also the fixed partial denture. It's also called a bridge in layman terms, and it's usually used to replace a missing tooth. And in order to do this, you have to crown two adjacent teeth, and the middle part where it replaces a missing tooth is called a pontic. And a pontic is attached to these two crowns, and it becomes a 3-unit bridge here. And then usually the pontic can be used. You see how the pontic contour here is very natural, and it can be used to apply a little bit of pressure to the tissue, and then the tissue will over time mold around the pontic, and these papillas will develop, and you get a nice aesthetic looking gum contour on the pontics. All right, I'm going to talk about some common types of materials that are used for these indirect restorations. All right, so first type, I'll talk about ceramic. So I'm not going to go into detail for each material because that's like a whole another lecture. So I'm going to talk about the basic things you have to know about each material. So ceramic, the biggest advantage of ceramic is that it is the most aesthetic material. However, ceramic, as you know, like for example, like the bathtub or glass, all right, it's brittle. If you drop a glass, it easily shatters, right? A crack can easily develop in a glass. So it is the weakest material. It is not very conducive to tensile stresses. It does well in compressive stresses. So it is the most aesthetic, but it's the most weakest. And oh, by the way, throughout the lecture, I'm gonna sprinkle in some digital dentistry here and there because prosthodontists are experts in digital dentistry. So we use a lot of digital technology. So I'm gonna sprinkle it here and there throughout the presentation where it's appropriate. So here's the first one. This is called Cad Cam. So CAD stands for computer-aided design, and CAM stands for computer-aided manufacturing. So these are primarily used for ceramic indirect restorations, like a ceramic crown, for example, okay? And how it works is the CAD component, computer-aided design, is exactly how it says. You design a crown on a software, on a computer, and then the computer-aided manufacturing component, the CAM component, is the mill that mills out the ceramic crown from a block of ceramic, okay? So the first step in doing this is you first obviously use a drill and prep the tooth into a crown preparation so it's ready for impression. But instead of the old manual way of doing impression, you can actually get a scanner and scan the tooth preparation and then upload it to a software on a computer. And then as you can see, you can actually design the restoration on the software. And all these blue spots are contact points with the opposing arch, because you can also scan the opposing arch, and then the computer will put the two bites together, and then you can actually have contacts. And you'll change the contour of the crown and here and there to get optimal contacts and the shape. So scan, first step. Second step is design. And then the third step is you upload the design onto a mill, and then the mill, which are basically automatic drills, will mill out the crown that you design on this block of ceramic. So it looks purple at first. So this is a lithium disilicate Emax block, and it's purple because it hasn't been sintered yet. Sintering is basically baking the ceramic. So before baking, the ceramic is purple. So it mills better because it's once it's baked, it's a lot harder. So it's harder to mill. So before baking, you mill it, and then it's purple. You add some glaze and stains to make it look more natural, and then you bake the whole thing. And then you can see here, purple here, and then after you glaze it and then bake it, it becomes the shiny, natural-looking ceramic crown. So on the left side here, this one is sort of the order is reversed. After you milled, you bake, then it becomes like this one right here. And then you put glaze and bake, and then it becomes like this. The order doesn't really matter whether you bake first or whether you glaze and then bake. So again, the main thing you should take away from this slide is that the steps are scan, design, mill, and bake. So now we talk about gold. So gold is the strongest material. Okay, another person came in here. Okay, so this is the strongest material out of the three materials. It has the best marginal seal, meaning the interface between the tooth structure and the restoration, that's the margin. And that interface is very fine. When you use a gold, you can get a nice fine margin when you polish gold. And it has the best seal as a result of that. Because in between the margin, if there's a gap, then bacteria can get inside and you're gonna have decay all over again, okay? So you want that interface to be smooth and sealed. And gold gives you the best seal. It's also the longest lasting. If the gold is done right, it can last like decades. I've seen gold last more than 30 years, sometimes even 50 years. The reason why it's strongest is because it's not brittle like ceramic. It's strong, but also it can withstand tensile stresses better because you know how metal is a little more malleable than like ceramic, right? It doesn't break as easily, right? It bends before breaking, right? Okay, so porcelain fused to metal, the last type. I gave a lecture on this in detail last quarter, but basically it's exactly as it said. So there's a metal coping underneath, and then surrounding the metal, there's a natural shade of porcelain that's covering the metal. So it gives you a good amount of strength and good amount of aesthetics. Okay, it's not as aesthetic as ceramic, and it's not as strong as gold, but it's like an intermediate between the two. So as a result of that, it is the most versatile crown. It's aesthetic, so you can use it on the front teeth, but it's also strong, so you can use it on the back teeth as well. Okay, so that's it for indirect restorations. Sorry, I'm running through this pretty fast right now because I started late, but I'll take questions towards the end. So now let's talk about aesthetic dentistry. Aesthetic dentistry is a big component of prosthodontics. So before we dive in, I want to start with this quote. Your eyes see only what the brain knows. So I think this is a really insightful statement when it comes to aesthetics because you can make something look really pretty and stuff, but you have to have a good idea of what's considered aesthetics even before you can apply, right? Your hand could be steady, you could have good hand skills, but if you don't have a good idea of how tooth should look like to look beautiful, then you're not gonna produce a good result, right? Okay, so aesthetic dentistry. It means dentistry that improves the cosmetic appearance of the teeth and the smile, and often concerns the anterior teeth. And the two most common types of procedures in aesthetic dentistry, when you say aesthetic dentistry, what people think of is ceramic indirect veneers or direct composite. So direct composite is a tooth color filling material. It's a resin that can also be used in the front teeth to enhance aesthetics. So here, let me talk about ceramic indirect veneers in a little more detail here. So as I said before, veneer is a partial coverage indirect restoration that covers the facial and incisal surface. And it will alter the tooth shape and also the shade, the color. But in order to do this, because it is an indirect restoration, you have to reduce the tooth to create some room for the ceramic, okay? Because ceramic has to have a minimum amount of thickness in order for it to be strong and long-lasting. So it usually takes about 2 appointments. The first appointment is you prepare the teeth, and then second appointment is you deliver the ceramic crown. Because after you prepare the teeth, you're going to take an impression and send it to the lab, and then the lab is going to make it, and then you bring the patient back, and then you cement the veneers. Okay, and in contrast, direct composite, so it's a filling material, so it's not as strong as a ceramic, like porcelain. But the advantage of composite is you can be more conservative because it's malleable. You can sculpt it. You don't really have to drill as much you can just be more additive instead of such subtractive. So, but the disadvantage is because it's weak, it's not recommended for large restorations. I think in the aesthetic zone, it's very commonly used to close gaps between teeth. When braces, going through braces is such a hassle and expensive, if the gap is not too big, you can actually use composite to close those gaps. And also, if you have like small decay or small chips on the front teeth, you can use composite to restore that instead of shaving down the whole facial surface for a ceramic veneer, right? It's more conservative. So it's indicated for more small chips or gaps between teeth, but it is artistically challenging because it requires your skill, your artistic skill to make it look natural. Whereas a ceramic veneer, you send it to the lab, so the lab tech is gonna make it look beautiful, not you, right? Another advantage of composite is that because it's additive, if it breaks a little bit, you can immediately add a little more back on. Whereas a ceramic veneer, if it breaks a little bit, you got to replace the whole thing. Okay, so it's a lot more repairable if you use composite. And this is my work. I did it on a patient, and you can see the patient has some chipping on the incisal edge and on two gaps here that she didn't like, but she was like in her late 60s, and ortho was not worth it for her. So we decided to do a conservative composite restoration, as you can see here. Turned out beautiful. She loved it. And okay, so again, digital design, digital technology here. So in aesthetic dentistry, a common digital technology that's utilized is digital smile design. So you basically take pictures of the patient to get some information, smile picture, headshot photo, and then it's like a 2D design because it's just a photo, and then you put it on your big computer screen, and then you use a software to um, overlay the outlines of what the ideal teeth shape should look like, okay? And you can then fill that outline with like a fake digital veneer. So as you can see here, the bottom where I'm pointing to. So these fake digital veneers can be used to sort of show the patient what they can be, right? So it's a great communication tool for the patient. And also, you can also send this design that you've made to the lab so they know what kind of shape that you're looking for, right? So it's a great communication tool and also a very great motivational tool to help patient accept cases. And there's also 3D smile design, which is the same thing, except it's three-dimensional. You use a scan, and then you put three-dimensional fake veneers on the scanned model, and then that can be sent to the lab to help make temporaries, or or you can also show it to your patient to show them three-dimensionally what they can be. So the main point of this is to facilitate communication with the patient and the lab to by visualizing the future outcome. Okay, so now I'm going to go over some common concepts in aesthetics when it comes to aesthetic dentistry, and I've actually divided them into 4 categories, okay? There's the face, things concerning the face. There's the smile, things concerning the smile. There's the gums, the gingiva, and there's the teeth, okay? So let's start with the face. So facial thirds, okay? So you can divide the face vertically into thirds to see if your jaws are too long or too short, okay? You can also divide your face in half, transverse wise, to see if, to look for symmetry. Some people might have jaws that are like shifted a little bit to the left or right, and it's gonna look asymmetric, right? So these are some aesthetic concepts in concerning the face. There's a lot of chat stuff. Hold on. Okay, I'll answer these questions at the end, okay? Also, lip support. So lip support means basically the teeth, front teeth, and then the gum on the front support your lips, right? So for example, if your teeth are really proclined, then your lips will be really protruded as well, right? If you don't have front teeth, then your lips will be collapsed, right? So especially for denture patients, they have no teeth, their lips are collapsed, and you want to restore their lip support to a natural contour. Okay, now let's talk about smile. When we talk about smile, we're usually talking about smile line. How high is your smile when you smile big, right? So some people have a normal smile line, which is pretty much, most of the incisors are showing, and maybe a little bit of the gingiva is showing, the papilla is showing. If you have a low smile line, a lot of the tooth is covered, as you can see here. And this is actually pretty favorable for aesthetics because when you do veneers or crowns, the margins are gonna be at the top of the tooth here. And sometimes the margins can show, but if you have a low smile line, the margins will not show. So it's more aesthetic if you have a low smile line. And if you have a high smile line, you have a very gummy smile. A lot of your gums show, and all the margins are gonna show. So this is more aesthetically challenging to manage. And let's now talk about gingiva. So when we talk about gingiva, we're talking about a few things. Gingival zenith, which means the peaks of the gingival margins. So as you can see here, these are the front 6 teeth, and you can see there's a line going through it, this yellow line. And you can see that the central incisors, their gingival zeniths, gingival peaks here are basically in line with that line. And at the same time, the canine gingival zenith are at the same level as the centrals, right? So that's usually what you want, the canines and the centrals to be on the same plane, whereas the laterals should be slightly lower than either of them, okay? And interdental papilla. So interdental papilla are these V-shaped triangular gum tissue that's in between teeth. And usually what you want is the papilla to be papilla between the centrals to be the lowest, and then the papilla between the lateral and the central to be higher than papilla between the centrals, and then the one between canine and the lateral to be higher than the one between lateral and the central. As you can see here, it's like going in increasing order from the central, low, and then higher, right? Okay. Midline, very important. Teeth. When it comes to teeth, midline is important. And as you can see here, Tom Cruise, he doesn't have a very good midline. So his number 9 central is basically on the midline. The middle of the central is on the midline here. So midline is assessed based on the face, and then you look at the teeth to see if the teeth line with that midline that you got from the face. I put Tom Cruise's picture here to remind everyone that aesthetics is very subjective. He has a shifted midline, but people still consider him a very good-looking person, right? Very handsome man. So, like we have all these concepts in aesthetics, what's considered beautiful, but then again, at the end of the day, it's very subjective. It's what you consider beautiful, or what most people consider beautiful. Another important aesthetic principle concerning the teeth are the incisal display at rest. So incisal display means your incisors, how much of your incisors are showing when your lips are at rest, okay? Not closed, but just at rest like this, right? And then you can see here, the ideal is about 1 millimeter or 2 millimeters of your central incisors are showing when your lips are at rest. If they're not showing, that's too little. And if they're showing too much, that's too much incisal display. So as you age, your lips tend to come down, okay? So as you age, your incisal display at rest would increase or decrease. It will decrease over time. Another thing is proportions of the teeth when you look at someone from the front, right? So here, the centrals are obviously the biggest when you look at someone from the front. They're the widest. And then the next widest is the laterals, and then the next widest is the canines. And there's this useful ratio that people use. Um, it's like the golden proportion or something like that. Is 1.6 to 1 to 0.6. Okay. Finally, buccal corridors. Buccal corridors mean the black space that show next to your buccal cheeks when you smile. So if I smile, this darkness is the buccal corridor. And ideal is for your teeth to fill the buccal corridor. So when you smile, you look like you have a nice wide arch, like on the top here. But on the bottom, you can see that there's a lot of black space showing when you smile. That means you have a very narrow arch, and that's not as aesthetic. But again, I want to remind you guys that aesthetics is very subjective. And you can see Michael Phelps, he has a very big buccal corridor. You can see his arch is very narrow and a lot of black spaces when he smiles. But people think he's a very good looking person. So it's very subjective. All right, now let's talk about color and shape. So I just want to let you guys know, some people think front teeth are like one plane, but actually it's more than one plane. It's two planes. Centrals have actually two planes to them. And not only just shape, but also the shade, the color. Tooth is not just one shade. From like the top to the bottom, the shade is like a gradient, okay? Usually it's darker near the gingival margin, and it gets lighter as you go to the incisal edge, right? That's why in this photo, dentists took this to send to the lab to communicate with the lab about the shade, and the dentist included, like 6 different shade tabs, right? Because the tooth is a gradient of shades, not one shade. And as you can see here, tooth there's a lot of anatomy on the tooth surface here. It's not just one plane. All right, let's go into removable prosthetics, a very, very important part of prosthodontics. It's probably the foundation of prosthodontics. So I'm going to broadly divide removable prosthetics into 3 categories. There's complete dentures, there's removable partial dentures, and there's overdentures. So complete dentures are these on the bottom left. It's a big piece of acrylic containing the teeth and the gum. They're all made of acrylic, and it will be replacing the whole mouth, whole teeth. Okay, so it's for people who have no teeth. Okay, that's why it's called complete dentures. Removable partial dentures is replacing only part of the arch. So as you can see on the top right, only some teeth are being replaced, and the rest of the teeth are kept, and a few of the teeth are being utilized sort of to hold the denture in place. And overdentures are same as complete dentures. They're replacing all teeth, but they have more retention thanks to implants. So these are still removable, okay? There's implants, but they're still removable. But they sort of click into place, and so it doesn't move around as easily. So removable prosthetics, So now maxillofacial prosthetic. So this is a branch of prosthodontics. You have to go to 3 years of residency, and then after that, you have to do 1 additional year of maxillofacial prosthetic fellowship in order to treat these kind of patients. So these patients are usually patients who have had cancer in their head and neck region, on their face or on their jaw, right? And they've lost a significant amount of facial structure, and they need that to be replaced so they can live a normal life. And maxillofacial prosthodontists are the ones who are doing exactly just that. Common types of prosthetics in this category include like the ear, the eye, the nose. A very common one is a denture with an obturator. Actually, this whole thing is called an obturator, but it kind of looks like a denture with like a big piece of acrylic coming out of it. So that piece of acrylic right there actually goes into the palate. This patient has lost a big chunk of his or her palate. There's a big hole in the patient's palate, and then this obturator will be used to fill that hole while also giving them teeth, right? If they have a hole in the palate, they can't speak, and with this obturator in place, they can speak. So it's quite a big difference for people. Okay, so I'm gonna go into a little more detail with each category. So complete dentures, probably the most important part about prosthodontics. I would say it's the foundation of prosthodontics because you learn about occlusion, you learn about aesthetics, you learn about like the vertical dimension, a lot of very important concepts in prosthodontics. I just want you guys to remember 4 things about complete dentures. Remember retention, stability, support, and aesthetics. I will go into detail about what each one means. So retention. So these dentures are actually one of my patients. This is my first denture patient that I treated. So retention means the resistance to vertical dislodging forces of the denture. Remember, complete denture is not an overdenture. It's not retained by an implant. It's only sort of staying on by creating a suction effect using the saliva and the gums, okay? So nothing physically is holding it in place. So retention refers to the denture's resistance to vertical dislodging forces. And let me demonstrate here what I mean by retention and complete denture. This is my patient.
Okay, open.
So try to hear for suction, okay?
Open a little bit.
I want to ask you, I hope that there's
There we go.
So that's how the denture stays in place, okay?
Okay, open.
Oh, sorry. So for the maxilla, for the upper arch, usually you can get a nice suction and denture can stay on pretty nicely. The tricky part is lower denture. So for lower denture, because the tongue is there, so maxilla, there's a whole palate. That's a big surface area that you can use to get suction effect. But the mandible, the tongue is there, and the tongue is always moving. And so not only do you have less surface area because you have no palate, but you also have the tongue, which is a barrier. Tongue always moves around and it's gonna dislodge the denture. So for lower denture, we usually try to rely on gravity and also rely on the patient's ability to adapt to the denture. Patient needs to sort of adapt his or her way of moving the tongue when they eat or speak so that they can keep the denture down. If you're lucky, you can get suctions, but it's not very common. So this is the lower denture of my patient.
Yeah, I wouldn't worry about it. You definitely gotta try.
So this one, I was lucky and able to get some suction. You can see that it's not picking up. There we go. Okay, so that's retention, resistance to vertical dislodging forces. Now we're talking about stability. So stability means resistance to lateral dislodging forces, right? So that refers to anything that's not strictly vertical. So it could be rotation or it could be tipping, okay? So how do you get good stability, right? One of the most important thing is called a bilaterally balanced occlusion. So let me explain this. So bilateral means both sides, lateral, bilateral, right? And balanced means both sides contact at the same time, okay? It's not one side contact and the one side's not contacting, but at all times, both sides are contacting at the same time. That's what I mean by bilaterally balanced occlusion. And the reason is because denture is not retained by an implant. If one side bites, but the other side isn't biting, then what's going to happen is the lower denture is just going to pop out because you have force here, but you don't have force here. So now denture is going to just tip and pop out. Does that make sense? So that's why you need both sides of the teeth to contact at all times whenever they eat, okay? So let me demonstrate here. This patient's gonna move his jaw side to side, and you can see that both sides are contacting.
Top hard, top to top. Side to side.
So it's not gonna fall out.
Forward and back.
Yeah.
Forward and back. Okay.
Okay. So that is bilaterally balanced occlusion.
Top hard.
Another thing that's very important for stability is you want to have nice and favorable contours that help increase stability. So for example, so the tongue part of the denture inside have to be concave because the tongue sits on it. If it's convex, then tongue is going to have a hard time sitting on it, right? So if it's convex, the tongue is going to move it around. But on the inside, if it's concave, then the tongue can sit on it like a bed and keep it in place. Let me show an example of a unstable denture. You can see that he just moves it and it easily rotates and rocks, right? That's an unstable denture. You don't want it to rotate easily. You don't want it to tip easily. Okay. So I'm gonna share this video real quick. So what happens if you are missing teeth? So missing teeth, there's a lot of consequences that come with missing teeth. And let me show you here. So you get bone loss, as you can see. Yeah, all that bone resorbs. If there's no teeth, bone has no reason to stay, basically. You can see that jaw getting smaller and smaller. Okay. So bottom line is, with missing teeth and you go for many years without teeth, the bone will start slowly get shorter and shorter, resorb over time, right? What is that gonna create? Your bite is gonna collapse. Your lower third of the face is gonna collapse. You're gonna have a collapsed vertical dimension, You're also gonna have a underbite here, like this, right? The reason is, and I can't explain it in detail today because it's too complex, but basically when the top arch and the lower arch resorb, it usually resorbs in such a way that the bite shifts, the relationship of the jaws shift. So you not only get a collapsed bite, but you also get a cross bite, an underbite. Finally, support, sorry, this is the second to the last point. So support means resistance of the tissue to vertical chewing forces. So when you chew with the denture, your tissue, your gums and the bone is taking the force. So it's ability of the tissues and the bone to vertical chewing forces. So obviously the gum and the bone are gonna have less support than teeth, right? Because teeth are designed to chew, whereas gums and bone are not. So you have to accept the fact that your chewing capacity is less. You have to tell the denture patient that you're not going to be able to chew hard things like you used to. And when you apply pressure on bone, it starts to resorb quicker. So you have to try your best to get a nice adaptation of the denture throughout the tissue, and so you don't have like localized pressure points. You have to make sure that the denture contacts the tissue surface evenly, so that when you chew, the force distribution is even throughout the tissues and not localized. Because if it's localized, the one point is going to get so much force, and that's going to have greater bone resorption. So support should be very well spread out. You don't have to know this. There's some areas on the top and the bottom jaws that are more favorable for support. They can take greater forces compared to other areas, but you don't really have to know the details here. Basically, the maxilla, the hard palate is the best place. The mandible, the retimolar pad, which is the back area here, and the buccal shelf are the best places. Okay, so aesthetics. An important part of aesthetics is the vertical dimension. So obviously, the denture patient's vertical dimension is closed, overclosed, and you have to restore it back to normal vertical dimension. And another aspect of aesthetics, you got to choose the right teeth for the patient based on the patient's smile line, and like patient's gender and patient's personality and things like that. If a patient is male and like has like a rough personality, you can go for like square looking teeth. Whereas if a patient is a female and maybe not as like rough in personality, you can go for rounded teeth. It all depends on their personality. And also you gotta make sure the gum aesthetics look natural as well. And obviously how high your smile is will matter, and where the midline is will matter also. And when I talk about aesthetics, you were talking about the front teeth, right? But front teeth are also very important for speech. Where the front teeth is positioned will influence the way you talk. So you have to consider speech into consideration when you position the teeth, okay? Obviously, I've talked about before, but how do the face have to be restored? Edentulous patients have collapsed video. You can see this gentleman, his jaw is completely collapsed. Okay, so digital dentistry again. Nowadays, we have 3D printing, and 3D printing can be used for many things. In dentures, we can actually start 3D printing dentures now, which makes the process way faster. Instead of waiting, weeks and months for a denture, you can have it in only 2 or 3 appointments now. Okay, so that is it for complete dentures, and this is I'm gonna move on to removable partial dentures. So obviously, it's for people who are missing only certain teeth, not all teeth. And it's made of not only acrylic, but also with a metal framework. And it's supported by not just gums, mucosa means gums, but also teeth. You can see that the metal here is supported by teeth. So some of the force distribution is transferred to the teeth themselves. So the bone and the mucosa are not taking all of the forces, unlike a complete denture. So here's an example of an RPD. Okay, and an important aspect of RPD is you have to design it in such a way, there's like a very special way to design it, taking into account the physics and the biomechanics of teeth, so that when you function on the partial denture, the remaining teeth can stay protected for a long period of time. If you design these metal clasps and metal rests in an unfavorable way, what's going to happen is as you function on the denture over time, you're going to eventually extract the tooth. So that's really bad. So you got to design in such a way that it's protective and not harmful. This denture here, this RPD looks really nice, right? But actually it's a very poor design, and I can suspect these two teeth will extract over time. Finally, overdentures. So basically, it's complete dentures that are supported by not only mucosa, but also implants. And because you have implants, you have better retention of the denture. And also, implants actually keep the bone from resorbing. It actually really slows down resorption. When the implant is in the bone tends to resorb much slower. So you can keep more of the bone. Okay, maxillofacial prosthetics, we talked about this. Okay, so this is an example of a maxillofacial patient.
Sometimes we create larger orbital facial prostheses.
You can see that she has
In this case, we utilize the stability of the patient.
Sorry about that. That's quite I should have given a trigger warning, but it's a cancer patient.
Sometimes we create larger prosthesis is always kept to an absolute minimum.
As you can see here, with the glasses on
thin,
and with some
flexible
makeup, it almost looks very like nothing was happened. And this is such a life-changing treatment for the patient.
Design.
All right, so in the interest of time, I'm going to move on. And the last section is implant dentistry, another big part of prosthodontics. Prosthodontists are, I would say, the specialists of implants. Okay, so I've divided implant restorations into three components. So these are fixed implant restorations, not removable. Like the overdenture is a removable implant restoration, but I'm only going to talk about fixed ones now that can't be removed. So there's a single tooth implant restoration. There's a multi-unit, which is more than one crown, like a bridge, and then a full arch, almost like a denture, but fixed implant restoration. So there's three components you have to remember about an implant. There's the post, which is the part that goes into the bone, looks like a screw. And there's the abutment, which is a connection between the implant crown and the post. And then you have the implant crown. So the steps, you extract tooth, and then you surgically place the implant post, and then you wait for osseointegration. So osseointegration means, osseo means bone, and integration means integrating, right? So bone is going to, over time, integrate into the threads of the implants. And once it does, the implant is going to become very stable. And that's when you can actually start biting on that implant and put some force on there, and it'll be fine. But until osseointegration happens, you don't really want to put a lot of force on the implant because you need to allow it to heal. Another one very important point. This is a very important point about an implant. Remember this for a quiz. So implants have to be, where the implant goes in the bone, have to be dictated not by where the bone is. Bone could be really thin, or bone could be really thick, or bone could be really tall or short. But that shouldn't dictate where your implant should go. What should dictate is the ideal position of the implant crown, just kind of like here, like smile design, right? Like what I talked about before. You sort of visualize the end goal, visualize where the teeth are going to be at the end, and then based on that, put the implant into place. And if there happens to be not enough bone, then you just bone graft. You add some more bone. But it should be prosthetically driven, not bone driven. Okay? And you can use a CBCT, cone beam CT, to 3D CT scan to scan the area where you want to place the implant, and you can actually plan it digitally. And then you can actually 3D print or mill a surgical guide where with these that can be stabilized on the remaining teeth, and also have these holes where the exact location of the implant is already planned. So you just drive the implant into that hole, and it will go into the perfect location. Makes surgery easier for everyone. So again, osseointegration means integration of the bone into the implant to make the implant stable. Now, the next step is you use an abutment. Abutment is a connection between the implant and the crown. And then the abutment actually will mold the soft tissue. You see this? it's actually molding the soft tissue. You leave the abutment in a nice shape on top of the implant, and then the soft tissue is going to cover that abutment. And over time, the soft tissue is going to mold. Just like how a pontic on a bridge molds soft tissue, the implant abutment can tissue train the soft tissue for an ideal aesthetics. So you can see here, the tissue has been molded to accommodate a crown here. And finally, you deliver the implant crown, and it looks just as new. Multi-unit implant restorations, pretty much the same thing, except you can have multi-units. You can have a bridge. I'm not going to go into details here. You don't really have to know the details of these. Basically, just like a bridge, you can do a implant bridge where you have the crown here and then the pontic here, okay? And you can also do a splinted implant crown, which is a little bit different. Splinted implant crown means there is no pontic. So there's 2 implants, and then 2 implants each get a crown, but the crowns are stuck together, okay? So that's called splinted. It's a little bit different from a bridge. So the benefit of splinted crowns, implant crowns, is that because the 2 crowns are stuck together, they actually distribute the force between the 2 implants more favorably. So guess which is the implant? All right, here's the answer. So this is the implant, this is a tooth, this is a pontic, and this is an implant, this is an implant. This is some really high level dentistry that, once you've mastered implant dentistry, you can achieve. Okay, finally, full arch implant restorations. I've divided these into 3 components, 3 different types. There's the acrylic type, which is made of completely made of acrylic. Obviously, you have these implants, but the prosthesis itself is acrylic. Or you could have zirconia, which is a type of ceramic. It's the strongest type of ceramic that's out there, zirconia. Or you could have one of these mixed with a metal, sort of like an RPD. So metal framework can be inside, that's not showing. And then the outside can be made of acrylic or zirconia, and that's called a hybrid. And we usually talk about this in terms of how many implants there are. Like all on 4 means the whole restoration on 4 implants. All on 6 means the whole restoration on 6 implants. So we like to just say all on X, because X can be any number of implants. An important principle about number of implants. More implants, the better, because more implants, the greater the greater distribution of force, right? More implants you have, right? Compared to if you have fewer implants, and each implant is going to take more force, right? And there's 2 types, full arch restorations. There's the one that has the gum component and the tooth component, and there's the ones that have only tooth component. Kind of like a really large bridge with multiple pontics. And these pontics will actually, adapt to the patient's gum and then mold the tissue to get nice aesthetics. And here's an example of a nicely molded tissue. And then you can insert the prosthesis like so, and it's beautiful. Yeah. All right, so next. Important part about full arch restorations. These are ceramics or acrylic. They're not natural teeth, so you got to protect them. You don't want the patient breaking them at night. Some people might grind their teeth, so you always want to make a mouth guard to protect them. Another way to protect them is you want to spread out the implants in anterior to posteriorly, sort of evenly. Not like too many posterior only or too many anterior only, but you want an even spread of anterior to posterior when you place implants. So you get a nice distribution of forces. And that's called the anterior posterior spread. You also want to make it cleansable. You want to make the surface that touches the tissues to be convex, not concave. So if it's concave, let's say this surface is concave, and you try to put a floss through it, right? You're not going to be able to clean that. But if it's convex, you can put the floss through it and just pull down and you can clean, right? So you want the tissue surface of the full arch restoration to be convex, not concave. Yeah, it has to be cleansable for long-term longevity, right? And another digital technology here, you can nowadays also mill not only single crowns, but you can also mill bridges. You can also mill full arch of bridges as well, usually in zirconia. And here's an example of a combination case. some of these are teeth and some of these are implants. And so this is a full mouth reconstruction. And you can see there's a lot of crowns, tooth crowns, bridges, and also implants, right? Implant crowns. So in prosthodontics, you incorporate all these principles like removable prosthetics, implants, and natural teeth, indirect restorations to fully restore someone's dentition. And here's a combination case with removable prosthetics and natural teeth, indirect restorations. From left to right, you can see the difference. And removables, the advantage is that it's cheapest option available, right? Some people may not like removables, but they can't afford expensive fixed restorations. In that case, they can get removables, and then they can function on those for a very long time. And I just want to say prosthodontics is very life-changing. Prosthodontists deal with a lot of very big, complex cases. We're the specialists of complex dentistry. So oftentimes we're sort of at the end stage of a patient's reconstruction process. Patient might get surgery and get root canals and their gums treated, but we're the ones delivering the end result. So we get to see the patient's reaction, and it can be very fulfilling, to see that. And this is American College of Prosthodontists, a great resource if you're interested in prosthodontics. And these are my references. All right, let me go to the Kahoot. All right, so let's start. I'm going over time here. All right, so please log into this Kahoot. The pin is going to show. There we go. Please log in.
Sorry, your screen is still on your PowerPoint.
Oh, sorry.
I think you have to reshare.
All right, I'll reshare. Can you guys see? Can you guys still not see it? Okay. Oh, there we go. So there's 80 people, so 80 people need to log on. Okay, 71, 72. Yeah. Almost there. 3 more. All right, I'm gonna give you 30 more seconds. Okay, I guess the rest of the people are maybe not on right now or something. Okay, so let's start. Starting now. All right. All right, what is not within the scope of prosthodontics? All right, pretty much everyone got it. That was too easy, huh? Root canals for endodontics. Great job, everyone. All right, next. How long is prosthodontic residency? seconds. Okay. 3 years. Most people got it right. 2 years close. Great job, everyone. Okay, which material is longest lasting? Ceramic, gold, PFM, zirconia. 6 seconds. Gold. Okay, most people got it right. Good job. Too easy for you guys. Oh, Kevin and Elizabeth are competing for the first. All right, let's see. Which is true about removable prosthetics? This might be a little too hard. Sorry guys, that might have been too hard. I made this too long. So don't feel bad if you got this wrong. I'll talk to them about this. So yeah, basically, complete dentures is only supported by gums, not implants. Overdenture is supported by gums and implants, not teeth and implants. And removable partial denture is supported by teeth and the gums. And overdenture has faster bone resorption than complete denture. That is not true because overdenture has implants, and implants slow down bone resorption. All right, last one. Which is true about implants? Okay, this is. Four seconds. Okay. So position of implant post is guided by the implant crown position and not the bone, right? Remember, it's prosthetically guided. I said that it's got to be on the quiz. And implants decrease bone resorption rate, not increase. Implant abutment osseointegrates the bone. That's not true. The implant post osseointegrates the bone. Implant abutment is a connection between the implant post and the implant crown, right? Implants are better than natural teeth. No, natural teeth are better, and everyone got that. All right, great job, everyone. I know that one question was a lot to read in a short period of time, so talk to them and give everyone credit for that. Congrats, Daria, Marisol, and Iman, and everyone else. Okay. So if anyone has questions, I'll be happy to answer them now, maybe for another 10 minutes or so, or 5 minutes maybe, because Hannah has to go soon.
Hey, John, can you make me a host?
Yeah, sure. Okay, questions. Okay, let me answer these. Yeah, onlay is harder because you have to, crown is like the same design every time, whereas onlay is different every time. It depends on the extent of decay. So the design is different every time for onlay, but crown is the same design every time. Sorry, I don't know which slide this is referring to. Do overdentures lead to less bone resorption? Yes, because the areas where the implants are, the bones sort of ankylose to the implants because they also integrate. So, and when you function on the implants distribute force to the bone. So bone thinks, bone thinks there's sort of like tooth there, so it's not going to resorb it easily. Whereas complete dentures, it's all, there's no implant, and without an implant, if you put pressure on the gums, it's actually traumatic forces, and that actually increases bone resorption. How do they implant if the bone? Oh, okay, it was answered. Yeah, sorry about that. I gave you guys too little time, 20 seconds. I didn't realize it was 20 seconds. So for that long question, I'll be sure to make sure everyone gets credit for it. Yeah, I'll be sure to give you guys credit for that question. Can you explain the concave convex? Oh yeah, so a fixed implant full arch restoration, the surface of the restoration that contacts the gums, the mucosa. So there's the interface between the restoration and the gums, right? And that area has to be cleaned because that's where all the food and plaque trap. And the only way to clean that is like you either use like a water pick in between that, or you can use like a floss, special type of floss it in between the tissue and the prosthesis, and then just move it around so it cleans the interface. But if the prosthesis is concave, the floss would not be able to adapt to the convexity. So let's say it's a full arch upper prosthesis, and then you put the floss through and then you hold down to clean it. If it's concave, the floss is not going to adapt to the prosthetic. But if it's convex, it will adapt to it perfectly, and then you can move it around to clean it. Hope that makes sense. Can you please send to us a recorded lecture? Yeah, I will send you guys a recorded lecture. As good prosthodontists, if you enjoy problem solving, and if you enjoy thinking about planning and planning and problem solving, is someone who should be a prosthodontist. And if you also like crowns and dentistry in general, like crowns, maybe even dentures, then you're a good fit. It's very mechanical. Prosthodontics is very mechanical, a lot of hands-on things. You spend a lot of time in the lab. It's also very artistic because you're like making restorations and you're dealing with aesthetics and all that. So someone who likes to use their hands, someone who likes to problem solve, those are the ones who should be like I know all of us are problem solvers and all of us like to use our hands because we're dentists, but the prosthodontists are like at another level of like being like perfectionists about these things. Yeah. Prosthodontists generally use labs. Yeah, or you can have your own lab too in house, just like any other dentist. You send things to the lab. Yeah. Prosthodontists do very similar things that general dentists do. We're just able to do it at a much higher level. Oh, because process is not very popular. For example, I'm like the one of the 2 people in my whole class, which is 108 people, 108. I'm like one of the 2 people who want to pursue pros. It's very unpopular because not everyone likes dentures, and dentures is usually the thing that puts people off from pros, because dentures are quite tough to do at first. Um, it's nothing like a filling or a crown. It's a lot more complex and very time consuming and tedious in the lab. So people tend to get turned off by pros due to dentures, but dentures is not the only thing in pros. Actually, a lot of pros nowadays is implants. What parts outsourced? Like after you take the impression, you send the impression to the lab, they send you back the crown, or you take an impression for the denture and you send it to the lab and they send you back the denture. You're taking a lot of impressions and then sending it to the lab, basically. Or you could actually scan, and then send the file to the lab, like digitally too. Because I want to become, I love being in the lab. I love making things with my hands, and I really enjoy dentures. I think it's very artistic, and I think it's very fun to think about. There's a lot of concepts that are big picture, not just focusing on one tooth, but big picture things like vertical dimension, the bite, occlusion, aesthetics. All those things are very interesting to think about. And also, I like planning like a complex case, like step by step, how should I go about this, or like that sort of thing. I like doing that too. Prosthodontists usually get referrals for complications. Like, for example, let's say an implant was placed not prosthetically driven, but driven by where the bone is. You know, I told you that's not ideal, right? So sometimes people do that, and then the implant ends up being placed in a very unfavorable position, and most general dentists will not be able to restore it because they don't know how to manage it aesthetically. So they would, a prosthodontist usually gets like complications, very difficult cases, or very complex big cases. We don't really get referrals for, you know, anything else like crowns or bridges. You know, it's usually for like difficult things. Okay, I'm gonna let Hannah go. And if you guys have any more questions, just DM me on Instagram on Dentistry, and then I can answer any questions you have. All right, I'm gonna let Hannah go now. Hannah's gonna talk about endodontics.
Thank you. All right, so I'm going to share my screen. All right, so can you guys see my screen right now?
Yep, I can see it.
Okay, perfect. Okay, guys, so I'm going to be going over giving a brief introduction to endodontics. We're going to cover a lot of information today too. So yeah, let's get started. Hold on, let me turn on my camera. Okay. So hold on.